You're listening to Medscape's In Discussion series on metabolic dysfunction-associated steatotic liver disease, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Drs VanWagner, Associate Professor of Internal Medicine at UT Southwestern Medical Center and Director of Digestive and Liver Diseases Clinical Research and the Internal Medicine Clinical Scientist Training Program. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers.
Welcome to Medscape's In Discussion series on MASLD. Today we'll discuss if fatty liver can in fact be reversed and what lifestyle changes actually work. And I am here today with my guest, Dr. Vincent Chen, who is an assistant professor at the University of Michigan in Ann Arbor, where he practices as a hepatologist and specializes in metabolic liver disease and fatty liver disorders. Dr. Chen is also an active clinical researcher whose work focuses on the genetics, risk stratification, and management of MASLD and MASH, and has publications that span all types of liver disease subtypes, including non-invasive testing and metabolic mechanisms underlying liver injury. So welcome to In Discussion. Vincent, I'm so excited to have you here with me today, and I thank you so much for being here.
Thank you, Lisa. It's really a pleasure. I appreciate the invitation.
Awesome. Well, I'm excited for our conversation. So, one question I had for you is how do you answer the question when patients ask you, can this fatty liver be reversed? Can I get rid of it?
What I tell people is that the answer is yes, but yes with an asterisk. In general, the earlier you catch it and the earlier the stage of the disease, the more likely it is that you can reverse it. You know, when you think about MASLD, there's sort of three big components to liver disease. There's steatosis, so fat accumulation. There's steatohepatitis, which involves inflammation of the liver. And then there's fibrosis, which is scarring. Fibrosis is generally the hardest thing to reverse than steatohepatitis, and steatosis is generally the most reversible thing. So when we think about mast cell, generally the earlier you can catch people before they have a lot of fibrosis, the more likely it is that you can fully reverse this process. Fibrosis can be reversed too, but it's just harder. It takes more in terms of reduction in cardiometabolic comorbidities to reach that. But it is reversible with intentional interventions.
All right. Well, let's talk about some of those intentional interventions. I think most of us are familiar with this concept, right? I mean, if you have fat in the liver or you have fat anywhere in your body that you want to try to reverse, weight loss becomes the primary thing that we talk about in terms of addressing that fat mass. And so, what is the most realistic weight loss advice that primary care physicians should be giving a patient with MASLD?
Generally, 5 to 10% is reasonable as a starting point. There's some very nice studies published a while back where they've looked at people, they've done liver biopsies in people before and after a lifestyle intervention. And then they looked at what kind of changes they saw in the liver depending on how much weight people lost. In general, losing about 5%, you'll start to see reductions in steatosis and the liver fat accumulation. If you're more in the 7-10% range, you can see reductions in inflammation as well. And usually for fibrosis, which, as I mentioned earlier, is the hardest thing to lose, you really want to be shooting for 10% or more weight loss. Of course, that's a starting point, right? I mean, I think that everybody started from a different place. It makes a difference if someone has a BMI of 30 to start out with versus 40 versus 50 or more. But I think as a rule of thumb, 5 to 10% is reasonable as a starting discussion.
I think that's such an important point, Vincent. And I love that you pointed out that where you start and where you end matters. And so percentage is one piece of the pie. I know when patients are talking to me too, in addition to the weight loss, which nobody loves to hear, a lot of times they want to focus more on sort of, well, what should I eat or what can I eat? And what kind of diets do you tell patients? What should primary care doctors be talking about in terms of dietary composition?
So I think we often talk about Mediterranean style diet, the setting of MASLD. I think this is where the best evidence is. Of course, when we say Mediterranean, we mean I guess I'll call it American Mediterranean. I'm not claiming it's what people actually eat who live in the Mediterranean area, but a diet with plenty of fruits, vegetables, nuts, legumes, lower in red meats. You know, fish is preferable. Fatty fish is preferable as a protein source, and then preferring whole grains over more refined grains, as well as limiting excess alcohol. And I think that that's where the best data stand in terms of long term outcomes. I mean, there's good literature at this point that adhering to a Mediterranean style diet is associated with lower risk of liver related complications, liver related death, and so on. The other thing that I often hear people asking about is keto,
Mm.
ketogenic
Yeah.
diet. very much a hot topic these days. What I usually tell people is that it has fantastic short term data. There was a really nice, I love this study. It came out in Cell Metabolism a couple years ago, and they took people who had severe hepatic steatosis and they put them on a ketogenic diet and got MRIs every 1 to 3 days
Oh my gosh.
uh, on, on these patients. I and it was amazing. Within 2 weeks, some of these people had a 50% reduction in the amount of hepatic steatosis they had based on MRI. It was really impressive. How sustainable is that? Hard to say, right? I mean, I think that cutting out carbs, I would have a hard time with it. I think a lot of people have a hard time with it.
I mean, I don't know what you're
Um,
talking about. In the state of Texas, we're totally fine not eating carbohydrates.
it's a challenge, and the other thing is that a lot of times you end up eating these very unhealthy fatty foods as a replacement, right? You end up having a lot of bacon as a substitute, which I'm not sure how much better is that for you in the grand scheme of things. But I think the short term data on ketogenic diet is very intriguing.
What about different dietary eating patterns? I know patients ask me a lot, right, about time restricted eating and intermittent fasting. Do we have data in MASLD on the effects of those types of diets?
I feel like we've seen sort of conflicting results to some degree on that. There was a meta-analysis that came out a couple years ago where they looked at randomized trials of intermittent fasting. The first thing I should say is that intermittent fasting kind of means different things to different people.
Yeah.
Um, Maybe I could just say a little bit about that. One common meaning of this is more technically called time restricted feeding, where you just give yourself an 8 hour window, let's say, for example, during the day that you're allowed to eat. So I'm only allowed to eat from 8 a.m. to 4 p.m. And you don't eat anything outside of that. The other diets that people sometimes do will be like the 5-2 diet, where you eat normally for 5 days a week. And then 2 of those days you have a very low calorie diet, like say like 800 calories a day. And then there are even these alternate feeding diets where you basically have a normal diet one day and a very low calorie diet the next day, and you just repeat this indefinitely. These all have some efficacy. Time restricted feeding has been shown in this meta analysis a couple years ago to reduce hepatic steatosis. And actually, the 5-2 diet has even been associated with reductions in fibrosis. So I definitely think it's an option. But I think at the end of the day, the best diet is a diet that you can follow.
Yeah.
When you start to do these really more challenging, onerous diets, some people can do it, some people do really well with it. I think that if you're somebody who's a snacker and that's where a lot of the calories come in, just restricting the time period in which you're able to eat, and it might cut down the snacks and maybe hundreds of calories a day just from that. If that's not the issue that's driving it, maybe less beneficial. So I think just having good conversation with your patient, trying to better understand what their eating patterns are, and having intermittent fasting in your toolkit is a way to go.
I love that. I love that so much. So I know another question that I get asked about from patients. We hear about the weight loss, and of course, the dietary piece always becomes first and foremost. But then on the back end and the back burner is the well, what about exercise? What about physical activity? And what do we know about exercise and its effect on MASLD?
Exercise makes a huge difference. There have been studies even showing that increased exercise is associated with very hard endpoints like liver-related death. It's very important. What I usually tell patients is based on CDC recommendations, which are 2.5 hours a week of moderate intensity, or hour 15 minutes a week of vigorous intensity, or a combination of the two, and then also strength training for the major muscle groups twice a week. That's good not just for liver health, but also cardiovascular health, insulin resistance, decreased risk of diabetes, and so on. I think that the other thing that's important to talk about in the context of exercise is that exercise has been shown in quite a few studies by now to lead to reductions in liver phenotypes, even if you're not losing weight.
Yeah.
Part of it is probably that if you're building muscle, you could be losing fat but building muscle, and your net weight's not changing, but the composition's changing. I think there's probably other sort of neurohormonal effects of exercise that are also contributing on top of that.
Yeah.
So definitely we got to tell people, yes, you're working out a lot. Don't get discouraged if you're not losing weight. You're still doing good for yourself.
Yeah, no, I love that, and I certainly talk to my patients about that a lot too, about the not the unseen benefits of exercise, right? Not a number on a scale, but the things that are happening on the inside. So we can join our cardiology colleagues in touting the benefits of exercise on the liver too, right?
Yep. Yep.
Wonderful. The other thing that I think comes up a lot, right, is sort of How do we think about the armamentarium that we have now for weight loss interventions outside of the backbone, which of course is lifestyle interventions? So we have medications, we have surgical and procedural interventions. How do you think about this toolkit when thinking about your MASLD patients?
Yeah, so the GLP-1s have really revolutionized care of not just MASL, but really all cardiometabolic diseases. I think just, sort of getting beyond the backbone of diet and exercise, the GLP-1s are making a huge difference. Semaglutide injections have been approved recently by the FDA for treatment of MASLD. That's in people who have fibrosis, at least
Right.
stage 2 to 3 fibrosis. But that's just the tip of the iceberg in terms of MASLD. I mean, a high proportion of patients who have MASLD meet criteria for treatment with a GLP-1 for diabetes or for complicated overweight or obesity. So I think that that's been making a huge difference. And anecdotally, I mean, I'm sure you have the same experience. I see huge reductions in liver steatosis and fibrosis. I mean, I saw someone a couple weeks ago whose ALT went from over 300 down to 30 after starting tirzepatide. Not for MASL, just this was just for diabetes.
How do you talk then to patients in terms of medication use? But there's also, I get a lot of questions, especially from my patients we talked about earlier, those with the BMIs of 45 or even 50. Do we think medication first, or where does bariatric surgery fit in the picture these days?
Of course, the backbone is still diet, exercise, and limiting alcohol intake. Realistically, by the time people see us, I mean, it's rare that we'll see a patient who's truly never made any effort to do any of those
Right.
things. I mean, I can probably count on one hand the number of times I've seen that. When we're seeing patients, I think we need to be thinking about pharmacologic therapy as well as procedures. I think that when we think about pharmacologic therapy, the GLP-1s are helpful because they are treating not just the liver, but other cardiometabolic comorbidities,
Yeah, it's a great
leading
point.
to weight loss,
Yeah.
reducing insulin resistance, and so on. I think that it's great in that context. In people who have severe obesity, class 3, BMI 50 or 60 or more, I do worry that even a GLP-1 might not be adequate. And these are patients where I am sending people for bariatric surgery evaluations. I think a lot of people have concerns about it because it is a invasive procedure. Sleeve gastrectomy is more or less irreversible, and Roux-en-Y gastric bypass has its own, certainly can have complications as any surgery can. But I've seen very good outcomes anecdotally with the patients that I've had who've undergone bariatric surgery. And there have been a number of studies now associating undergoing bariatric surgery with decreased risk of liver decompensation, liver-related death, and so on. The other thing that's exciting is bariatric endoscopic procedures, such as endoscopic sleeve gastroplasty being kind of the big one that we talk about these days. I think we're going to be seeing more of that.
I agree with you. My own clinical experience, similar to yours, patients are definitely hesitant for the surgical trigger. When we bring this all together, and I think from a primary care doctor's perspective, you've got a MASL patient sitting in front of you, and they've got fatty liver disease, maybe they've got type 2 diabetes, they have hyperlipidemia, they have obesity. How do you think about the framing of a lifestyle intervention?
For better or worse, the same interventions that help with most of these other cardiometabolic comorbidities that are associated with MASLD will help with MASLD. The lifestyle factors are really very similar across the spectrum of cardiometabolic comorbidity, whether it's liver related or otherwise. In terms of medications and so on, I think that in general, if people have MASLD with some significant amount of fibrosis, we should probably be prioritizing for treatment of diabetes things like GLP-1s or maybe even SGLT2 inhibitors over some of the other medications if you have that option. That's really, I think, one of the primary ways in which the presence of MASLD might affect how we think about the other cardiometabolic comorbidities. I think we have good evidence they're safe, they're effective in people who have MASLD too. So we certainly shouldn't shy away from prescribing statins if they're indicated, regardless of the presence of MASLD. And then otherwise managing hypertension per standard of care, I think is fully appropriate.
Excellent. So I guess I want to give you an opportunity here. If we're asking primary care doctors walking into their clinics tomorrow, they're seeing a MASLD patient again. What is one thing that you hope that they take away from this episode about lifestyle interventions and the potential reversibility of MASLD?
This is a really important point. I think that one common misconception I hear from other providers and patients alike is that having MASLD is somehow a very severe problem that's likely to lead to advanced liver disease. And I think that it's really important to highlight that of course, it can cause cirrhosis, it can cause liver cancer, it can cause a lot of complications, but in most people it doesn't. And in the majority of people, the thing that's probably more important is that it's associated with increased risk of cardiovascular disease and extrahepatic cancer, which are far and away more common than liver-related death and sort of the MASLD, the general MASLD population. One of the big messages I would like people to get from this episode is that MASLD, in many cases, is reversible. It's not a death sentence. It doesn't mean that you're destined to develop liver-related complications or anything like that. And that early intervention is important because the sooner you can intervene on it and treat it with these different lifestyle factors that we talked about, the more likely it is that you can fully reverse it and truly improve long-term outcomes.
Well, awesome. Thank you so much, Dr. Chen. Really appreciate all your amazing insights today. We have, of course, covered the strong possibility of reversing fatty liver through lifestyle changes and lifestyle interventions that work. I hope that we remember that it is reversible, particularly early. I think that's the biggest point we've talked about today. The earlier you intervene, the more reversible this disease is, but it is going to require our intentionality. Weight loss target, we want to target usually around 10% body weight loss. Though certainly 5% can reduce some of that liver fat, but 10% is really that magic number if we're going to move the needle at all on the inflammation and the fibrosis aspects. And the diet quality matters, as we've talked about. Mediterranean style patterns, or American Mediterranean, as we said, reducing those processed foods, increasing those fruits and vegetables, and thinking about how we might be add on that time restricted eating component to the dietary composition. Exercise has independent benefits for the liver, so we should add that to our counseling that we give patients even without significant weight loss. And of course, in the end, we're treating the whole patient here. What we recommend for MASLD is not really that much different than what we recommend for general cardiometabolic health in our patients. And so we should add this to the diabetes, lipid, blood pressure counseling that we're already giving our patient population. So thank you, Vincent, so much for joining us today. And thank you to our audience. This is Dr. Lisa VanWagner for In Discussion.
Thanks for listening to Medscape's In Discussion Metabolic Dysfunction Associated Steatotic Liver Disease podcast series with our host, Dr. Lisa VanWagner. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on metabolic dysfunction associated steatotic liver disease.